is ridiculous.
Try glass of coffee.
Um, All right, thanks, Pamela. Good morning, everyone. All right, give me just a second. I'm gonna get everything pulled up here. Can everybody see my screen? Awesome. Morning. My name is Chris Tapley. I am the VP of Business Development at American Exchange. I'd like to take a second and say thank you for joining us this morning, and I hope everyone has had the opportunity to at least have their first cup of coffee. 2020 has been a very daunting year for all of us. So before we start, I also want to say thank you to each and every one of you you've done during this pandemic. None of this has been an easy time for anybody involved, but it had to be done, and everyone has stepped up to the plate. So thank you very, very much for all your hard work. A quote by the great American poet Maya Angelou has stuck out to me throughout my entire career. If it is true that a chain is only as strong as its weakest link, isn't it also true a society is only as healthy as its sickest citizen, and only as wealthy as its most deprived? This quote by her really resonates with me and with all the work that we do in public health. We work on the front lines, and of most of any career, we really take heed to Lady Liberty's call of give me your tired, your poor, your huddled masses yearning to breathe. On these front lines, we're looking, we're listening. We need to ask ourselves, what are we hearing? What do we see? And how do we respond? And in order to achieve health equity, we must first identify what the problem is. The best approach is to look at the numbers. Here we see health insurance disparities broken down by race. The notable highlights in this particular study is the range between the highest level and the lowest level was 21.3%. That's a pretty wide range between the highest level of coverage versus the lowest. And the overall average of people with healthcare coverage at the time of this study was 85.3%, meaning that roughly 14.7% of this group was without healthcare coverage. So taking a look at this high level information, we need to dig a little bit deeper to dive a little bit more into the problem and what's causing this gap in healthcare equity. So what do these numbers so what do these numbers tell us? A good measure is to look at the number, look at the statistics as far as people that see a primary care physician. So in this slide, we're looking at the number of folks with a PCP. This is an important measure because a PCP can serve as a healthcare air traffic controller, so to speak, directing us where to go when issues arise, as well as through preventative care, so we can stay proactive in our health, as well as prevent any unnecessary hospitalizations or development of chronic conditions. I pulled this graph simply to highlight a very telling statistic. Of this population, the average that saw a PCP was 76.3%. The highest population was at 82.2, with the lowest being at 69.4. So of this entire population, it was still roughly a quarter on average of folks that did not see a primary care physician. So as we dig a little bit deeper and a little bit further, we need to look at what the causes and what the effects of this is. So looking at the causes and effects. So what are some of the causes that we see that are, keeping people from seeing that primary care doctor, from being proactive in their healthcare as compared to being reactive? First being the high cost of healthcare. We can all kind of empathize with healthcare prices. You go to a doctor and, for 15 minutes and most of that being sitting there waiting in a room, for a doctor to tell you got a cold or something like that, you get a bill for $100. Or say you need to get an MRI or something. If you go to a hospital, you pay $5,000 for that MRI. But if you go to another facility, like an outpatient facility, you could pay like 500. So not only is the healthcare cost high, they range all over the place. So there's no rhyme or reason, it seems. With that high cost of care, another cause would be the lack of insurance coverage. If individuals don't have the means to pay for that particular healthcare coverage or they have that payer support, they're probably not going to go until it's a dire emergency, and then they're going to go to the emergency room. The next would be lack of service availability. We really see this in more rural areas where there's not necessarily a high number of doctors available, not a high number of specialists available. With more technology coming into play, we are seeing a higher reach with telehealth. And since the onset of COVID, that's kind of accelerated that particular process. And then another cause of that would be lack of culturally competent care. When you go see a doctor, you want to see someone that you can trust. And if they don't know your background, there's no shared experiences, and there's a cultural gap, you're not going to trust that doctor. And if you don't trust that doctor, there's a good chance you're probably not going to go back to get that preventative care, to get, whatever that particular situation might be. So looking at the causes, what are the effects of this? Well, first you have unmet healthcare needs, such as like chronic condition management. So if someone's diabetic, they're hypertensive, hypothyroid, whatever their chronic condition might be, if they're not under regular care, there's a good chance that they're not maintaining that condition, which can lead to a snowball effect with health outcomes. The next would be delays in getting care. That cough that you should probably go get checked out is not going to get checked out and eventually possibly turn into pneumonia, which could turn into a hospitalization depending on what your situation might be. Whereas, a simple antibiotic could have taken care of it. Well, now you're looking at thousands upon thousands of dollars for care. The inability to get preventative services. This one is a biggie. I'm a very, very big Marvel fan. So when, a month or so ago when Chadwick Boseman passed away, that one really hurt. I mean, it was, Black Panther. He died of a cancer that, if caught early, has a very high long-term survival rate. So if someone that is not getting that preventative care, they're not getting those checkups, then they're going to miss those screenings, and the chances of a disease like this having a detrimental effect is much higher. And then, kind of like we talked about with pneumonia example, preventable hospitalizations. So looking at the problem, looking at some of the causes, looking at some of the effects, we need to look at some of the ways that we can address these causes and effects. So American Exchange has worked directly with Ryan White programs across the country, which serves a population that is one of the highest risk categories. HRSA's mission is the race to zero. Zero means zero, all populations, no exceptions. Working with Ryan White at QHCs and CBOs across the country, we developed a managed benefits platform that works directly with case managers to keep people in care by giving them the keys to healthcare service, health insurance. From there, we even ensure that the premium is paid on time and that there's no lapse in coverage. The first piece of this puzzle was being able to get access to the service itself, or the enrollment process. So what we did was we made our services available on any platform available for the patient, whether that be web, phone, fax. If someone needed a carrier pigeon, we would send them a carrier pigeon with an application, whatever that might be. In 2020, access to this information and to this should not be a problem. There's too much technology available. This should not be the blip or the hang up to keep someone out of care. The second step was having a dedicated account manager at American Exchange work directly with case managers. This includes system integrations from our platform to platforms like CareWare. The third step was ongoing management. The process didn't end at enrollment. We maintained what are called policy checks monthly to ensure that there are no surprises with premiums or any other kind of administrative issues that happens with insurance coverage, because we want to avoid these at all costs. Because the last thing any of us want is a patient showing up for their doctor visit to get their retrovirals, to get their prep, to get whatever, whatever that they're going to that doctor for, to be told by someone up front that their healthcare coverage has lapsed, or they don't have healthcare coverage anymore. So what that person is going to do is they're going to leave, and there's a good chance they're not going to come back. So all of that progress that they had made in their care plan is now they've fallen kind of back through the cracks again. And that's what we want to prevent. So working through our platform, we need to see what those results are. So working with various programs across the country, the results that I've listed here account for approximately 12,900 lives over a wide range of population types and environments, ranging from very rural populations, such as in Missouri, to very urban populations, such as Miami-Dade County in the state of Florida. Through these dedicated efforts, we were able to see an increase of enrollments of up to 23%. So for the overall mission, for the Race to Zero, what does that actually mean? The ultimate goal here for the Race to Zero, what does that really means is a suppressed viral load. So looking at these particular statistics and these particular numbers, those with no health insurance, there is only a 69% suppression rate of that viral load. Whereas with that healthcare coverage, there's an 86% viral load suppression, which is a roughly 17% increase from those without healthcare coverage, which is closer inching towards that 100% mark, because it is, after all, it is the Race to Zero. So in conclusion, to kind of wrap things up, the three basic steps to improving healthcare outcomes are going to be increasing access to care coverage through a managed solution, geographic availability to care, whether that be actual brick and mortar doctor's offices or an increase in availability of telehealth platform, psychotelehealth, as well as specialty telehealth, and then finding a provider that the patients trust, whether that is speaking the same language, same cultural background, whatever that particularly might be. So once again, I want to take a second and thank everyone for taking the time this morning to listen. I hope by the end of this, everyone is at least one cup of coffee deep. And if you would like to discuss our outcomes or platform more, please stop by our booth at any time. My name is Chris Tapley with American Exchange. Thank you so very much.
Good morning, everyone. Can everyone hear me okay? Yep. Sounds good. I'm excited to present with you today about how to achieve health equity through a statewide coordinated care network. A lot of you may have heard about NC Care 360, which is the statewide coordinated care network in North Carolina right now. And I know that we have been making our rounds for the past 2 years to really make this a robust network, try to figure out how this can and cannot work and how to get those kinks out. It has been a very long process, but now that we are really starting to get the feet under us around this coordinated care network, we really wanted to kind of take it to the next level and really dive into how can we achieve health equity through this network. So I have a quick presentation for you today to talk about that, and I'm happy to answer any questions or concerns you may have towards the end. So again, my name is Georgina Dukes. I am the Southern Region Network Director for Unite Us. I actually came to Unite Us from Duke Health. back in 2018. So today is my 2-year anniversary. I can't believe it's been 2 years already. I came to Unite Us as a community engagement manager and just since been promoted and worked my way up to the position I'm in today. I also put my email here for those of you who may have questions or concerns or just want to give feedback. Please feel free to email me at Georgina@Unitus. I'm happy to talk with you, try to work through this, because we really want to learn from you all how to make this a better solution for the community. So the key takeaways we want you to have today is we want to understand the critical need for a scalable solution rather than a one-off pilot. We know today a lot of people are just so tired of hearing the term pilot. We pilot everything, right? Like, can we just do something that we know that's going to work for the community? So this is the need for a scalable solution rather than piloting ourselves down to a tizzy. The second part is we want you to feel empowered to initiate these conversations in your own community. We really would like you all to start thinking about how to set up local community advisory councils in your counties to figure out and get buy-in to figure out how this could be even better than what it already has done after we did that first walkthrough for NC Care 360 in your communities. And then last but not least, have a better understanding about how the movement towards value-based payment is an opportunity for these community-based organizations and nonprofits to not only rely on grant funding, but more sustainable methods, right? Like the healthy opportunity pilots or the innovation that our health plans are doing, like Blue Cross Blue Shield, United Healthcare, those individuals. So those are the 3 key takeaways that we definitely want you to understand today. So let's go dive into the state of health. I'd just like to recap on this. I know you all really understand this more than anyone, but as we know, 80% of health happens in the community. We know this. We know that, right? But the thing is, providers can't communicate across sectors, right? So if we know 80% of the reason someone is unhealthy is due to what they experience outside of the healthcare system or the public health department, then why can't we communicate to those organizations or get insight into that life outside of healthcare so that we can better heal the patients, right? So health and social care organizations lose their visibility after the patient leaves their 4 walls. And what we want to do, and the ultimate goal of that in North Carolina, is to heal that. So here are a couple of business cases that we know just from a health perspective, right? Transportation is the #1 reason patients fail to make appointments. Delayed discharges for patients is because they don't have food at home, right? For those patients that like are diabetic, have congestive heart failure and things like that. And then readmission and delayed discharges for patients unable to return home or homeless, right? 80% of emergency room visits could have been treated with preventative care. And then homeless people spend on average 3 nights per visit in the hospital 5 times a year, right? So this is dollars associated with taking care of people's social needs in the healthcare system. And we really want to get away from that and have a more equitable approach with healing our community. So the way that we believe we can have a more equitable approach with healing our community is moving beyond just measuring activity. I know one of the first things that we've seen across North Carolina is that everyone has their own screening tool, which is amazing, right? So we're all trying to figure out a way to measure what are the social needs that our client knows, right, or has. So 20% of screenings identified nutrition as a need. 105 members search for nutrition needs. And then here are 8 providers in your local county that can offer food assistance, right? So just knowing a need exists doesn't tell you enough about how to address them. So just knowing that, like, hey, someone has a housing need, but you really need to know how to address it. And that is the ultimate goal of the NC Care 360 initiative, to really create that equity. So from shifting from measuring activity to learning outcomes, right? So what you really need to know in order to create equitable communities, to have an enhanced public health infrastructure, is you need to know requests for emergency food assistance are met by the network in an average of X days, right? Like that's the type of measures you want to know that you feel like will be more meaningful. Members that request food assistance have better long-term outcomes if they enroll in this organization versus this organization, right? Like, you need to know that type of information. Mothers who successfully enroll in WIC have fewer health complications than those who do not, right? But we need to be able to have that data available at the community level, not just at the state level, right? Or the national level. We know some of these numbers, but you need to know that for your community. So we want to know what social care interventions produce, what outcomes for which members, and why. And that is the part that we really have to rein in on now that we're taking NC Care 360 to the next level. So just a little bit about Unite Us. I know that many of you may not know we are a partner of NC Care 360. Unite Us is a technology platform that creates a community infrastructure for connecting health and social care. So our two pieces that really make us successful is that we have a community building expertise. So some of you may have interacted with our community engagement manager. So we hire locally in every state that wants to work with this technology platform. So there's community engagement managers here in North Carolina. We also have network health managers. We also have account managers for all these health systems and hospitals coming on. And we have operations analysts who are there answering your questions whenever you email support@unitus.com or chat in. But outside of all that community and people who are really understanding North Carolina, live here, breathe here, we have the technology platform. So it's flexible and it's a scalable platform, and it is constantly evolving. Right now, one of our number one things we're thinking about is how to translate the entire platform into multiple languages, right? So not everyone here is English speaking. So can we translate the language into Congolese? Can we translate the language for the Congolese community? Can we translate the language into Spanish? So we're trying to think through how to be a more equitable technology platform outside of having people that look like the community. How can we make the technology more equitable for those in need? So this is how Unite Us creates equitable communities. We have community engagement and training, right? So a lot of you may have participated in the community engagement and training piece. If not, no frets, email me. We would love to have you work with our community engagement managers. We have data and insights on equities and disparities. So you can see data by age, gender, race, ethnicity. We're adding some additional fields in there so that we can make sure, like language preference and things like that, so that we can make sure that we're understanding what are those key disparities that our community is experiencing. We partner on strategy and policy development. One of the key partners here is the North Carolina Department of Health and Human Services. So we're really working on that, not only in North Carolina, but in other states as well. We support place-based initiatives and community investment strategies. So some of the data that we saw in the platform helped escalate that to leaders at the state level. And that's how we got some internet infrastructure too into local communities, especially during this pandemic and challenging time. We helped them see like where low referrals were or where we had a low rate of engagement, which is the reason why they needed more internet infrastructure, because we are a technology platform. Another part is a platform for coordination and support for strategic initiatives. So right now in North Carolina, we're focusing on 5 different initiatives. One is rural equity. We really want to highlight the rural community and make sure that they're receiving the same attention as some of these more urban counties. The second one is our tribal and indigenous communities. We really want to build better relationships and make sure they're receiving the social support that they need. The third one is maternal and child care. So we're really trying to work with the women's health initiatives in the state, WIC, and all of those to make sure we're focusing on that. The fourth one is criminal justice. So, and injustice involved individuals. So we've been working with adult corrections and the juvenile justice system. And then the fifth one is immigrants and refugees. So we just really want to support these 5 groups. And we know there's way more groups than that, but that's just what we've been focusing on to better our software around and better our engagement approach around, because that's how we really want to create equitable communities. So just wanted to let you know that those are happening. We would love to partner with you on that in your community. So just a quick, another quick thing about Unitas is that our connection to this work. So Unitas is not only in North Carolina, although I know this is the North Carolina Public Health Association, but your colleagues across the nation may be working with Unitas and not know, because we go by a different name in each state. So right now we are in almost 40 states across the country. North Carolina, again, was the first statewide coordinated network, but as you can see, we are growing rapidly. So the dark blue represents where we have active networks. The kind of medium blue represents where we have networks in progress. So we have about 10 states in Central America that is coming on. So the Nebraska, the Iowa, the North Dakota, the South Dakota, and then the light blue represents where we have no active networks at this time, which still we would love to build networks there. So if you have any connections, please let us know. So health equity, this is the main piece that I wanted to kind of dive in today, is that we have to take the technology up to the next level. So we want to onboard all of these community-based organizations, government agencies, healthcare systems. Like, we want all of those individuals on the platform, but we really have to focus moving forward on creating health equity and getting those places of trust on the platform. So is it a place of worship? Is it our faith-based community? We really need to get them engaged. Is it a barbershop? We really need to get them engaged. Youth and community centers, all those places that people trust in the community, we have to start getting them better engaged at the local level so that your counties and communities have robust networks. Without those front doors, then the data will continue to look skewed and show that only a certain population is getting the services they need. And we don't want to perpetuate the disparities that already exist in the community. So we encourage you to start thinking outside the box on how can this be a scalable solution in your local community and across the state, by not only thinking how can we get a community-based organization and a healthcare organization on. What are those other organizations that may not offer services, but will be that front door of help for people in need? So this is the standard PowerPoint of just like what is it like to navigate services, right? You have someone in need. They may go to a church to get service for housing. They also may go to a healthcare organization and then end up getting referred to food. It's just a really chaotic cycle. And what we end up wanting them to do is to have a no wrong door approach, right? So you have a client that goes to a care coordinator, and then that care coordinator logs into the Unitas platform and makes a referral for whatever that need is. So in this example, it is rental assistance. And then from there, the rental assistance provider can send a referral for food. So we want that simple, streamlined approach where we're not burdening the client to go out and seek all of these services and hear no constantly, but we also don't want to burden the care coordinator and the social workers either to have to consistently Google resources, use outdated sheets. We want the technology to take that burden away so that they have a simple way to just connect an individual to the service they need. We just want the A to get to B, and then we want it to be a source of truth for anyone working with that client so they can understand their experience. So you've all have seen this before, just that we are HIPAA compliant, we're FERPA compliant, FIPS 42 CFR Part 2 for mental behavioral health and substance use. We also have a DV summit coming up. So we just received approval from VAWA, and this is a really great opportunity for us to get all the domestic violence agencies on the platform. So please let us know if you have any thoughts or concerns or you would love to attend. I'm happy to invite you. These are the features in the software. You have screening, you have electronic referral management, you have assessment and care plan management, bidirectional communication and alerts, and outcome tracking. But it is a really nice tool to send referrals. It is a referral software where you can track outcomes and really understand how social needs are being met in your community. And so these are just the structured reports that you would get from a healthcare or a public health perspective, right? You want to know how the social needs are being resolved in your community. So they're being resolved positively or unresolved, right? So are they receiving full-time employment, part-time employment, or if they're unresolved, why are they unresolved? You still need that data to make interventions for your communities. So client refused services, client relocated, client is unable to contact, right? All of those things still happen. We just want to give you the data to do that. So this is our first statewide network. And just to go a little bit into NC Care 360, for those of you who may not have heard, it started from the collaboration with the Medicaid transformation that DHHS was leading. So the standardized screening tool, if you go to DHHS website, is available. It asks questions around 5 key areas, which are housing, employment, food, interpersonal violence, and transportation. There's the map of social determinants of health indicators that DHHS also created. That is through a partnership with the North Carolina State Statistics Department. So it maps across the entire state down to the census level. We also have the Medicaid transformation that's coming up that everyone talks about. So North Carolina is doing healthy opportunity pilots because they received the 1115 waiver. And now they can reimburse these community-based organizations for the services they provide to Medicaid beneficiaries. So if someone is healing a Medicaid beneficiary when it comes to housing, employment, food, interpersonal violence, or transportation, they can now be reimbursed for those services that were traditionally free, which is a huge way to now create sustainable funding for these community-based organizations that do amazing work across our state. They also want to align enrollment with existing resources, so streamline those efforts within DSS and local health departments, and then also looking at the workforce. So I know you all know with the COVID response, they have community health workers across North Carolina who are Spanish speaking and who are really getting into the community and helping with contact tracing. And those people who screen positive for COVID, they're automatically doing wraparound services for them so that they can isolate, quarantine, and then heal and get what they also get meal deliveries and things like that, or transportation to appointments. So amazing work that the North Carolina Department of Health and Human Services is doing around healing the community. And then NC Care 360, again, is just a small part of it, but it's the foundation for all of these things around the bubble, because we are the technology infrastructure that provides the standardized screening tool, that provides data for the map, that healthy opportunities will be built off of, and that the community health workers are using. So again, NC Care 360 is a partnership within North Carolina. Unite Us is the technology infrastructure for NC Care 360, but again, it could be called something different in another state, right? In Georgia, it's called Unite Georgia, and the Nebraska, Iowa, North Dakota area that I mentioned earlier is called NEHI. So depending on what state you're in, they all are building this same infrastructure, and they're all modeling after North Carolina, which is amazing. North Carolina is one of the most innovative places to be when you are in public health. So you see Unite Us, you have North Carolina Department of Health and Human Services, you have the Foundation, Foundation of Health Leadership and Innovation, and then you have United Way 211. So all of these partners are really making this a great experience. And then this is our 3-point goal: to build a system of health, to leverage existing and new infrastructure, and to provide visibility and accountability across organizations. Now, this is my last slide, and I just love to end on this slide because I really believe it speaks volumes to what we've done in North Carolina. So NC Care 360 is now live in 100 counties. So as I told you in the beginning, I started at Unite Us back in October 2018, and they just told us hey, you have to get in all 100 counties by December 2020. So you have 2 years, go, right? And so everyone thought this was insane. There's no way this is going to happen. So we started out in January 2019. We launched our first 3 counties with the innovative group led by Kathy Colville at Cone Health in Guilford, Alamance, and Rockingham. So they launched in March 2019, and we hit 50 counties right at December 2020. So we were ramping up in December 2019. So we were ramping up in January 2020, saying, okay, let's go. A big part of our community engagement is bringing all these people together in one room, breaking out in work groups and just brainstorming. How can this software work for the food industry? How can this coordinated care platform work for transportation? And COVID hit, right? So the big part of us coming together and brainstorming and things like that, that piece had to go away because of COVID. So we were just thinking, oh my gosh, there's no way we could hit this timeline by December. Now that COVID has impacted the way that we gather and brainstorm with the community. So we were just trying to think through how can we delay this timeline, and then so many organizations end up reaching out to us. When the closures started happening, community-based organizations all from across North Carolina were reaching out and said, "Hey, I'm in Duplin County. I know we're not scheduled to launch until October of 2020, but can we go ahead and launch now? Because we have so many people we need to help and we need to shift virtually, right? We can't be in the office. We have to do different things." So we decided with the leadership of DHHS way, we decided to open up onboarding to all 100 counties. So as you can see, it quickly scaled from March, where we only had 50 counties, to June of this year, where we had at least organizations offering housing, employment, food, interpersonal advisory, transportation in all 100 counties by June of this year. So we launched 6 months ahead of schedule in being statewide, which is amazing. But this is only due to those community-based organizations that said, hey, we need this software to be more innovative and to address the equity in our community and the disparities that's happening due to the COVID closures. So with that, I wanted to conclude my presentation because I really think this speaks volumes to how this software can create an equitable approach and how we need to continue to build. This is only phase 1. We still have 29 more phases to go, but the next phases are about equity and making sure we have those key organizations that those historically marginalized and oppressed communities can trust to be able to meet their social needs. So I'll pause right there and see what questions do you have for me or for this presentation. And I guess I could look in the chat to see if anyone chatted in any questions. So I see from Margaret, it says, is there a place where we can see all the names using the Unitas system? Yes, if you go to unitas.com, you will be able to see there's a map and you can click on the map and it'll break down who is the organizations in each state. So like if you click on North Carolina, it'll say NC Care 360. If you click on Pennsylvania, it'll say who's using in Pennsylvania and things like that. Any other questions that I could address for you all? Yes, the screening tool is available on NCDHHS. So if you go to, or if you just use your Google in your browser and you do NCDHHS screening tool, it's one of the first searches that pop up, and you can just click on that, and they have it in English and Spanish on their website. Thank you, Beth. Okay, are there any other questions? How can schools become integrated and connected? Sorry if I missed this. No, that's a great question. So we are currently trying to launch with schools. Some organizations have had, or some healthcare systems have partnerships with the local schools, or public health departments support the local schools. So we are really trying to onboard schools, and that is something that we're focusing on in 2021. Now that with COVID, we kind of have shifted to be more like focused on health equity and like marginalized communities and making sure those front doors are on. But we definitely want the public schools to get on. So we have to work with DPI, the Department of Public Instruction, to make sure we are doing the right measures to get the public schools on. We've already presented to all of the public school social workers. So that's our first step, and we're just going to continue to build that relationship and get them engaged so that we can get them on the platform. I think we only, at this time, only have probably like 5 or 6 public schools on. Oh, yes. Thank you. Great connection. I will let you know, Susan. Any more questions? Okay, can I share some particular successes and challenges so far? So I will say some of the successes are that people are getting healed. Like if you have a referral, people are getting healed and their referrals are getting accepted within 0 to 7 days. I know our original goal across the state, everyone voted because they saw the data from our NC Serves networks that they get people needs addressed within 2 business days. So our goal was for everyone to at least get 2 business days and get their needs met. I think it's a little bit different because we're working with a more broader population compared to the veteran community. So 84% of our referrals have been getting resolved within 0 to 7 days. So I think that is, once they become a case, that is a definite success. So I think that's amazing. We also just have stories of people who have just been connected and healed and who are now living quality lives and getting employment and things like that. But I would say the biggest challenge that we've seen so far is just buy-in. I think that buy-in has been one of our largest issues, that when we are in a community and there are certain dynamics in that community that we're not aware of, because again, like I live in Durham County, but I may not be aware of some of the politics in Granville County, even though like I might drive through there, I know Durham County, right? And so those types of challenges really create issues in the community. So when we're in that community trying to create those relationships, but there's politics at play, there's people who have created their own thing and they don't want to use something else, right? And rightfully so, because it took a while for this to happen. I mean, we just started in January 2019. That has created a lot of challenges where you just don't want to rub people the wrong way. You just want to help, and you don't want to make someone or create a bad relationship because they've created their own thing. So I think our biggest challenge is getting buy-in and getting people to understand how this can really change the game for our community. But it's only as strong as the community. It's only as strong as the people who buy in. So right now we are at 1,500 organizations across the state. We have over 6,000 users, and we're constantly growing. We actually just signed our contract with Duke and UNC. So those are 2 large health systems that are bringing all their physician practices and hospitals on. So we're about to see a lot more growth in the network now that we have more buy-in from some of those larger agencies across the state. Do I have any tips on how to present this platform to community groups so they will join? Yes, definitely. So I think the main thing to do is just to help them understand like how referrals are made today versus how referrals can be made through the platform. So I think people feel that this is a technology solution and there's the digital divide and we just keep throwing software at things. But the ultimate goal of the platform is just to help someone get connected to resources more accurately, right? So I think as long as you can calmly demonstrate, like today, we're giving someone a sheet of paper and expecting them to go out and figure out how their needs can be met, right? And we're not getting any data back on that. We don't even know. Like, and I can relate to that. I feel horrible, or I felt horrible in my past career when I would give someone a list of resources and say, like, I hope it works out, you know, and you have no idea if it actually does. But through the NC Care 360 Coordinated Care Network, we have a way to send referrals electronically where we're not giving someone a piece of paper and hoping it. It's a better, more accurate way. Now, are there going to be some times where the person on the opposite end didn't answer the referral? Yes, especially right now during COVID. Nonprofits are closing every other day because they're losing funding and the resources are going down, but there's still resources available that can lend for more accurate referrals. So I would say my main tip is just to help them understand what you do today in a traditional referral versus what you can do utilizing this platform to help them understand how it can create community. And then, especially in your community, talk about the data that you can get. I know data speaks dollars, but having the local mayors, having the county leadership at the table and talking about the data you can get from the platform to understand the results and understand which zip codes have the worst outcomes. Like, we know this anecdotally, but we really need the data behind it so we can understand where to reinvest in the community. Thank you, Chris. He said, this is a great platform. Giving a piece of paper and hoping the patient is able to complete the process is a Hail Mary. Yeah, it's really uncomfortable situation, and we really want to improve that. Any other questions? Well, I thank you all. Here we go. Have y'all had success working with Ryan White programs? Yes, so that was brought up early on when we first started presenting, and I think it was brought up by maybe Wake County. So we've had some organizations who onboarded who use Ryan White, and they use NC Care 360. So they use Ryan White for, and I believe it's HIV, AIDS, like those type of funding. And then they use NC Care 360 for all the social needs for the patient. So yes, we totally have organizations that use both, and we've created workflows for those organizations to understand, like, when does Ryan White end and when does NC Care 360 plug into that workflow to help the client. So I'll stay on and just answer whatever questions you may have. Georgina, thank you so much for providing. Thank you. Okay, no problem. So I'm happy to stay on as you all leave, just to see if anyone has any other questions for me, but I really appreciate your time this morning. I really hope you understand how we're kicking into phase 2 of achieving health equity through the NC Care 360 platform. And I hope you understand how hard all of these partners have been working. I know I only represent Unite Us, but the Foundation for Health Leadership and Innovation has been an amazing partner. United Way 211, they are the community leaders, like funding so much of the work that happens locally. And they're the call center throughout, just in general and throughout all this COVID, as well as NCDHS spearheading all of this work and Expound as a data repository piece. So this work cannot be done without these partners in North Carolina. So please let me know how I can connect you better or how we can partner better to really elevate health equity now that we have launched statewide. Thank you.